We had a blessed night, and we will probably have an even better program today. Thank you for coming and waking up after this long program yesterday. So I just want to give you a background on the roundtable discussion. This is an introduction how I have seen the history, the small history in my humble life, I would say, as compared, of course, to the experts attending, how this evolved in the past years as we recognize the evolution of the metastatic process in breast cancer. Mostly, I try to focus on the lymphatic regions to some part, but as you know, clinics is ahead in this means, and pathology is behind to some extent, and also the molecular studies. So as we look at breast cancer, I think it's evident that this is the most common cancer in the Western world, and the incidence is the highest among all cancers there. And the mortality, as you see the data, especially in Europe, we have something to solve here. We have a long way ahead to work on to get even better outcomes for breast cancer patients. However, in the northern countries, you know, they have the best outcome, and also the USA and Spain. If I look at just stratified breast cancer in the European region, which is the most common cancer among females in Europe, you know, there is no surprise, not even another tumor displays. All is just on the top list with breast cancer. And this means we have, at least in Hungary, we have about 8,000 breast cancer cases a year, and almost half of them are metastatic at the time of diagnosis. And as we stratify this outcome incidence by stage, we can also recognize that the survival curves are a bit parallel at the beginning for stage 1 and 2, but it's evidently decreasing as we go forward, and with advanced stage lymph node metastatic or even distant metastatic cases have, of course, a poorer outcome. So what we have learned and what we teach probably and what we believe still is the process of breast cancer formation, that the tumor develops in the breast. Likely it metastasizes to the lymphatic system, as we see, you know, in our practice, and goes to distant organs. This is what we have thought, and we have been taught, and this is what we teach today. But this is not necessarily the truth. Intravasation and using the vessels, tumor cells metastasizing, that's the lowest amount of substance we recognize as pathologists, right? And in the clinics, that's what we can see, but we cannot see just a higher resolution. Like yesterday, we had a talk about circulating DNA. Probably there is another mechanism, not only metastasizing via cells. So if we put together the picture, or try to put together this process, this is, of course, how a phenotype develops, goes into the vessels, and goes to distant organs. But if on the upper diagram there is a fast-growing tumor which is metastasizing within 1 year, approximately, but the question is, why is it metastasizing after a few years? So if it keeps that dividing pace, and it's dividing in that manner, you just don't have the time to develop those metastases. It should finish the patient's life within 2 years. So even for instance, for triple negative breast cancer, there should be something that happens after the first years. So the probably what we consider now is tumor dormancy. So these tumor cells are hiding somewhere, they stop dividing, and then they reactivate somewhere in the system. On the opposite, down below, there is a slow-growing tumor. And if it keeps that pace of, for instance, 1-2% of Ki-67 index, and it's proliferating in that pace, it would take 50 years to develop metastasis. So that's another question we don't understand now. So they should accelerate, or there should be something like a clonal selection that is going on there. There have been multiple models. You don't necessarily need to read this to understand, so we always think how metastatic process would develop. And the latest and most horrifying method, which is not even on this chart, is that maybe tumors metastasize without cells. They discharge nucleic acids into the circulating system, and they kind of infect those cells, macrophages, or other stem cells in the system that would turn into tumor cells. So this is an interesting phenomenon. It was already described almost 20 years ago by Larry Norton and Joan Massaguet at Sloan Kettering, that they tried to figure a mathematical model about the pace of metastasis. So they observed how the tumor cells or the metastatic size grows in a patient, and then they could only make up their mind if the metastasis is communicating with each other. So it's not just the process that it goes to the brain and it's there. It gives metastasis to the primary tumor back. It's communicating with cells. That's how mathematically the tumors grow. It's going into other metastases, so it's more like an interconnected cities with highways between the metastases. You know, this is a famous paper from more than 20 years ago by Chuck Peru from, at that time, he was a PhD student at Stanford, and with a huge collaboration with Norwegian and US and many other countries, they described the subtypes of breast cancer, which is genetically based. So it's not only histology, but genetics and transcriptomics. And the main subtypes, what they described were the basal, that's the worst, I would say, and the HER2, of course. But for the HER2, there was a development in the past 30 years with antibody-based targeted therapies. And the most common was the luminal phenotype, which is the hormone receptor positive. It could be either A or B. Interestingly, they described the normal-like tumor there, which was not reproducible. So we consider that like a pollution, I would say, or a mistake, because they sequenced and they put on the chip normal breast tissue instead of tumor. So probably that was contamination earlier. All right. If we wanna go further, we have looked at an interesting phenomenon. We dissected the sentinel lymph nodes, and we have patients who have metastasis beyond that. We wanted to see whether we have a threshold. If we have a sentinel node metastasis present, what's the size of the sentinel node or the primary tumor that would predict actually whether there is more sentinel node metastasis in a patient. So we have found a threshold of 6 millimeters and the primary tumor to be 26 millimeters. This was a small cohort. The reason I show, because Anna Sapino, this is Janina Kulka, my mentor at that time, in the middle, but Anna Sapino, another Italian pathologist, found also 6 millimeters. So we were very happy. After 3 years, she called Janina, and we also found 6 millimeters, and that's kind of like a threshold that's reassuring. So in the time being, the surgeons worked hard, and all the team. And the data came out, for instance, for the Emerald study, where the 10-year survival analysis allowed to do irradiation instead of axillary dissection. I don't want to go too much into details with these because I know there will be others presenting on these data as well. I just wanted to give a heads up on the history, and I try to focus on the molecular mechanisms, what we have seen behind these, how we understand that. So getting back to the metastatic processes, we hypothesized that from the primary there will be other metastases growing, and we could also imagine that it's a parallel evolution. And of course, the treatment is very important here, because it's another factor that gives an evolutionary pressure on the clones of breast cancer. So by the treatment, we modify the original process that would go on in a patient. And that's not the same anymore as we introduce treatment. So we divide, we interfere with the evolution within a patient as we give the therapies. And there are mutations under pressure coming up, or other subclones going ahead. And actually, it's really hard because the main issue is that by the time we have a metastatic formation, there is little to no effect on the good drugs to stop the metastatic process forever. We can delay it, we can interfere with it, we can slow it down, but in the end, it's not curing the patient. We can just slow down the process going ahead. So we wanted to understand a little bit more of this picture, and with a work group in Brussels, Christine Desmet, we were lucky to sequence multiple metastases from the same patient. So this was a post-mortem study of 10 breast cancer patients, and by copy number alterations in the DNA and by deep sequencing analysis, we could put together the life histories of phylogeny of how these metastases developed in each case. So there is a normal DNA, and there is an alteration, then comes the primary tumor. And sometimes, the majority of the primary tumor is different from a core group of cells which give metastasis. So that's why sometimes, the primary tumor is a little bit off the way as well. So the real root of metastasis we don't even know probably. It exists, but we don't really know whose are those guys, whose are those cells. And the other very interesting phenomenon was that we have seen, you remember I mentioned this metastasis self-seeding communication between the metastases. We see that, for instance, for that patient down on the right, that it's communicating between the adrenal gland and the ovaries, how they communicate and go back and forth. It was a very interesting thing that we have looked at the axillary lymph node metastasis and how they correspond, how they could be responsible for further metastatic processes, because at that time we thought, it's a linear thing, primary breast, lymph nodes, distant organs. And we only had a few axillary lymph nodes. We didn't even focus on this, but we have seen only one case that would metastasize from lymph nodes. So all others are just stopping there. So probably our immune system stops the tumor. Not in all cases, but in 90%. And they just don't go beyond that. So we have seen the trials coming out, and then was the ACOSOG Z0011, and I think Professor Kovács will also talk about it, so I don't want to take his talk. Here, T1 and 2 tumors were included, and they were randomized to get only sentinel lymph node metastasis or a complete axillary dissection. There was a breast irradiation and systemic therapy. However, no third region irradiation was allowed in these patients. And as you see, the curves are almost completely on each other, so there is little to no effect on whether we dissect the axilla beyond that or not. This is stratified, of course, towards a good prognostic group of patients with smaller tumor sizes, but it was really interesting to see that in light of our sequencing study. A few years later, Johan Hartmann from Karolinska, he could also perform a sequencing study. And he had 20 patients there. And he has seen the same thing. It was quite reassuring. So hard that he gave the title to his paper after this whole autopsy multi-metastatic sequencing process of 20 patients. He also put together the phylogenetic trees. And I'd like you to focus on this, on the lymph nodes here as well. I tried to, yeah, I gotcha. So this is the lymph node here, you see? So this is the germline. He also has seen that primary is somewhere different from those clones which are responsible for metastatic processes, but lymph nodes are just a dead end. And then you see other metastases, other regions, how it goes. I just pulled a few patients to show you that lymph node metastasis is how far from all the others. I like to believe that this is not, the lymphocytes themselves, and these are still tumor cells, but he's a pathologist and a really good one. So I believe, and also in our cohort, we have seen that these are dead ends from the metastatic process. From the view of the metastatic process, you see multiple lymph nodes were sequenced from many patients, and they just don't seem to metastasize to further places. And this is what I wanted to show you. These are the lymph node metastatic patients. This is the probability of metastasizing to any of the organs from the lymph nodes. So it's 0 or 0 point something. So that's quite unlikely that tumors would spread out from the lymph nodes. Of course, I cannot go by Gabor Czerny if I talk about lymph nodes here. And he made a tremendous work in the past decades. He planned to come here, but he was busy with other duties. And quite recently, he put together a review about his expertise and all the guidelines, very much likely now affecting also or touching upon the lymph nodes which are after treatment, so after post-neoadjuvant treatment evaluations. We are happy to see that with Christine Desmond, what we just started. She has been working on this for decades. There are now 14 centers across the world to do such studies and understand more of the metastatic processes. And we are really happy that we put our university also there, besides others. They have amazing programs and they have amazing work behind this, and they work a lot on understanding breast cancer progression very well. So just a few months ago, or 2 months ago, I can say, the Swedish Xenomax study came out, and they were again randomizing patients, but these were also including larger tumors, T1 to T3, not only the best prognostic patients, and they underwent sentinel lymph node dissection versus axillary lymph node dissection, and of course, even for larger tumors, we can now see that the dissection is almost the same in this means, and all the factors favor sentinel node biopsy as compared to the axillary dissection. So, I'm a pathologist. I think different, maybe a little bit on the things, and I like this Swiss artist who makes order, of everything. Basically, it can be a beach side or even a French fries with ketchup. But I think we slowly get there, and we understand more and more with time, and we look forward to the data that will support the clinics. Thank you so much. I was hoping to get some time back. Yeah, almost finished. Yeah.